if you can help us with understanding, the role of GastroPanel in dyspepsia, as a gastroenterologist, practicing gastroenterologist, where do we implement this test and where do we introduce this? How would you?
Yeah, it's a very important question, I think. In fact, to me, GastroPanel is a very essential tool in gastroenterology, and especially in the field of stomach function, because it's very, very important to establish the amount of acid produced every day for stomach for a patient, to assume if a patient is infected by HB infection, to establish if the infection produce damage in the stomach, to be sure that a therapy with PPI is effective in such a patient. All this information could be received by a unique, very simple and cheap blood sample named GastroPanel, based on 4 parameters. I mean, pepsinogen 1, which is a non-invasive surrogate for acid production, and in fact we proved by comparison with the gold standard, I mean the juice collection by nasogastric tube and measure of maximal acid output, that GastroPanel, in particular pepsinogen 1, is fitting very well in different situations. I mean, when secretion is normal, it is very low, as in the case of atrophic gastritis, where is height, where in the case of patients suffer from peptic ulcer, based on pepsinogen 2, which is definitively a marker for gastric inflammation, I mean gastritis. And we know that we have 2 kinds of gastritis, one dangerous, named atrophic gastritis, the other not dangerous, named non-atrophic gastritis. And the atrophic gastritis is based on achlorhydria, I mean low levels of pepsinogen 1. And this is possible because pepsinogen 1 had a very, very important negative predictive value, 98%, when the target is atrophy of the stomach. The non-atrophic gastritis is closely related to HP infection, and in fact, by means of GastroPanel, we are able to establish if the patient is infected or not. When we find, in fact, high levels, more than 15 microgram liter of PG2, and at the same time high levels, more than 30 units of IgG against the bug, for sure in that stomach HP is present. Lastly, by measuring an hormone named gastrin 17, 17 is the number of amino acids, and gastrin 17 is based on 17 amino acids, is the isoform of gastrin secreted 90% in the lower part of the stomach, I mean the antrum, and is responsible for negative feedback between acid and gastrin. It means that if my patient assume a drug like a PPI for lowering acid, we expect that gastrin 17 increase. On the opposite, when we experience atrophic gastritis, no acid, we expected that gastrin 17 is at the same time high, and when we find without assumption of PPI low levels of pepsinogen 1, high level of gastrin 17, the diagnosis of atrophic body gastritis is sure. And I like to remember here the role of autoimmunity in this process, because when patient is affected by autoimmune gastritis, the mechanism is that antibodies against parietal cell producing acid are able to destroy all these glands, to destroy all the glands named chief cells producing pepsinogen 1. It means that when a patient experiences antibodies against parietal cell, low levels of pepsinogen 1, high levels of gastrin 17, the diagnosis is definitively of autoimmune gastritis. And we establish, based on 5 published studies, that this autoimmune gastritis is closely related with another autoimmune disease, I mean autoimmune thyroiditis. And in fact, 20% of such patients, usually female, with thyroid autoimmune disease, experience autoimmune gastritis. Problem is that the majority of patients with autoimmune gastritis are asymptomatic. They show only symptoms related to thyroid, cured by hormonal substitute. But by using GastroPanel, it's possible to find 20% of subjects asymptomatic for troubles of stomach. We experience a precancerous condition, so in which is mandatory to perform an upper endoscopy with biopsies. And speaking about gastric biopsies, I'd like to remember that now a new classification for gastritis named OLGA is able to predict the patient more prone to develop lasting ear gastric tumor. And we studied 420 patients in different situations by using GastroPanel and OLGA, and we were able to demonstrate a very nice relationship between histology, the gold standard histology of the stomach, and GastroPanel. In particular, when diagnosis histologically was of Olga 3, Olga 4, the only 2 dangerous situation for the progression to the cancer, serology was perfectly fitting. On the contrary, when GastroPanel is normal, for sure histology is normal.
Thank you. And when it comes to the clinical use in dyspepsia, as in the patient comes and is on PPI and has been, complaining of dyspepsia, what other insights can we get? So the idea is, should we subject him to endoscopy and GastroPanel, or what is the best way forward?
Yeah. This is a very interesting question because, of course, first of all, dyspepsia is a very common disorder. Second, I am an endoscopist, by the way. All gastroenterologists and doctors at the end prefer to know what happens inside the stomach, and in general, the best way to provide this information seems to be to perform an endoscopy. But in the majority of patients with dyspepsia, we don't find by using endoscopy any lesion. And when the suspect is reflux disease, in 60% of such patients, we don't find erosions. It means that we need a test to study the function of the stomach. And so for dyspeptic patient, I suggest as the first non-invasive tool, GastroPanel, because I'm able, by means of a unique non-invasive test, to exclude a role for the stomach to cause dyspepsia, a role of HP infection, a role of reflux disease. So we could eventually study other disorders like motility disorder, for instance, or biliary tract disorder, or disorder in diet, or other situations.
Perfect. So you mean to say we can distinguish between acid reflux and non-acid reflux with the help of GastroPanel?
Yeah, this is a hot topic now for us, because the majority of reflux disease patients experience acid reflux. But diagnosis is not difficult when the patient experience typical symptoms like earthburn or regurgitation. But it's difficult to make a proper diagnosis when symptoms are so-called atypical. I mean, chronic cough, or asthma, or non-cardiac chest pain, or chronic pharyngitis, laryngitis, and so on, or nocturnal apneas, etc. In that cases, we lack of a gold standard, because if we perform endoscopy, in the majority of such cases, until 70% in patient showing atypical presentation of GERD, endoscopy is negative. The gold standard is a second level tool named pH impedance, but is definitively not for all people. So once more, GastroPanel is able to distinguish between subject with possible acid reflux, when gastrin 17 level is ranging from 0.1 to 0.7, and patient with non-acid reflux. In that case, my experience is that gastrin 17 is always low, but not so low when as the patient is experience acid reflux. In fact, in that case of non-acid reflux, gastrin 17 is ranging from 1 to 2.5.
Okay, perfect. And when it comes to HP IgG, there is where the big question is that why IgG, why not IgM? And if IgG, then how different is it from the urea breath test or the rapid urease test or the stool antigen?
Yeah, IgG alone are not useful because they could be expression of immunological memory. So if you use only IgG, by the way, we use IgG because we are speaking about the chronic infection, not acute, when we use IgM. The IgG are very slowly in lowering when HP is disappeared from the stomach. It is exactly the reason why we use in GastroPanel two parameters. I mean, a marker of inflammation of the stomach, pepsinogen 2, and IgG. When we found high levels of pepsinogen 2 and at the same time high levels of IgG, for sure we experience in that stomach an HP infection with non-atrophic gastritis.
And how about urea breath test? And because that also helps us.
Yeah, urea breath test is a very nice test with very high diagnostic accuracy, 96-98%, but I'm a doctor. I'm not interested to know if people working in India is infected or not, because this is the only information that your rapid test could offer. But as a doctor, I'm interested to know the damage that in my patient Helicobacter pylori produce in his stomach. And GastroPanel is able, in fact, to offer information not only about the presence of the bug in the stomach, but also about the damage.
Perfect, thank you. And coming to the question of performing GastroPanel, as in we talked about dyspepsia, we talked about acid, non-acid reflux, talked about HPY-IgG. Now, the question is how corroborated the GastroPanel report is with the endoscopy findings.
Yeah, we proved results of GastroPanel by comparing with the gold standard for all gastroenterologists, I mean histology of the stomach. And in this case, it's possible to find the same diagnosis by serology, GastroPanel, and by histology, almost classified according with Olga. I'm an endoscopist. I prefer to know before perform endoscopy what happens in that stomach, and such information is very easy to collect just by using GastroPanel. Then if GastroPanel is normal without alarm symptom, there's no way to perform endoscopy, which is unuseful. Otherwise, I have before all the information to perform very well my endoscopy.
Perfect. And last thing is, like, if you can tell a little bit about your experience with GastroPanel as to how long you have been using this test, what are the most interesting findings you have observed with using this test in the population, and if you can just talk about your key studies that you have conducted using GastroPanel.
Speaking about dyspepsia, of course, the goal is not necessarily for the specialized, but for primary care. But the first step is to convince all the gastroenterologists about the appropriateness to use GastroPanel in such subjects. Then, when gastroenterologists and endoscopists and surgeons are convinced about the properties of GastroPanel in everyday professional life, then as a cascade of education, it's possible to reverse this information to the GPs for routinely use of this test. And the last issue is speaking about general practitioner and patient, the use of PPI. Because I remember that we are now using PPI without any knowledge about the amount of acid produced every day by the stomach. As, for example, to use statins to lower cholesterol without any information about the level of cholesterol is not rational. And we perform a study in older population over 65 in my country, and 70% were under PPI. Well, 30% of such patients experience atrophic gastritis. It means PPI was absolutely unuseful. So another indication to use GastroPanel is to ameliorate the appropriateness of use of PPI. And lastly, when my patient is under PPI for GERD, for instance, and patient is not controlled with symptoms, if I measure levels of gastrin 17, I could explore the compliance of my patient. In fact, if gastrin 17 under PPI is low, for sure compliance is low.
Perfect. Thank you.